Hello, I'm Donald McCauley and welcome to this BMJ Leader Conversation. Today I'm talking to Sanjiv Ahluwalia. He's leading one of the new medical schools in the UK. Quite an adventure. But let's take it back to the beginning. Where did it all start?
I started my education as a medical student at Guy's and St Thomas's in central London. I qualified as a junior doctor in 1994. I then went on to become a GP trainee. I subsequently, in my clinical career, became a GP partner in a practice in Stanmore, where I was for 20 plus years. And then recently I moved from there to another practice in North Finchley. In parallel, I have been working predominantly in postgraduate medical education for about 20 years until I took the leap from postgraduate medical education into undergraduate medical education about 2.5 years ago. And in my current role, I've been there for 2.5 years working at a university in east of England called Anglia Ruskin University. And as you rightly pointed out, ARU is amongst the kind of newer batch of medical schools that was set up back in 2017.
So tell us about your current role and the challenges.
So my current role has been to really oversee the development of the School of Medicine at Anglia Ruskin University, to help to develop the program, the curriculum, to ensure that the student experience is a positive one and is relevant to the needs of the NHS in the local area. And also, it is to also develop beyond medicine itself a number of other programs that support and meet the needs of the local population of Essex.
Now, to get to that position, I mean, it's not the standard role to go through general practice and postgraduate general practice. That's a remarkable achievement. What are the skills you needed to learn along the way?
I think one of them is perseverance. There remains, I think, a culture. What would general practitioners know about education beyond general practice? And I think helping colleagues to realize that actually educational principles are transferable across sectors is part of it. The second, I think, is working with colleagues from very differing perspectives, and understanding that win-win situations are what one has to be good at creating if one wants to make an impact and really start to change things. So having that ability to kind of create win-win scenarios is really important. I think it's also really quite important to maintain one's own values and standards throughout the work one does. And that's really important in my experience as well. Most often people will have similar values to myself in education, but occasionally tensions do emerge. And it's really important to be true to yourself if you want to carry on doing this work in the context of a leadership journey. Sometimes it's also about being able to challenge in a constructive way the sort of long held and embedded perspectives that people have. The world is an ever changing place. Expectations are ever changing, and how one engages with that ongoing change process and helping others to kind of come on the journey, it seems to me to be absolutely crucial. The final one I would probably flag before I stop boring everyone is I think it's really important to be adaptable. in my journey, I've pretty much found that I need to adapt to a set of very different circumstances literally every few years as governments change, as policy changes, as the needs of the population change, or as sometimes I describe it, whatever the whim of the latest fad in education tends to be. So sort of being able to adapt to those changing, buffeting circumstances seems to be quite an important part of the journey that I've been on.
You've spoken about complex systems change, and I know that's an area that you're interested in. How do you prepare yourself for that?
I think people talk about the difference between purpose and vision, and I'm a firm believer that anyone who has a crystalline, sharp, clear vision of the future is almost certain to fail. So I tend to keep a strong focus on my purpose and try and encourage my team to acknowledge the general direction of travel without getting fixed on a set destination, because in my experience the kind of sort of political and the educational landscape keeps changing, and with it the vision may very well change as well. So rather than get frustrated with not achieving a kind of sort of a vision, I tend to prefer to think about achieving an overarching purpose. So that's one thing. The second is being flexible about the nature of change in complex systems, and noting that one will require different approaches for different problems, even within the same complex system, and having the ability to work on parallel activities at the same time, but with differing tools, seems to me to be quite an important part of dealing with a complex system. One of the things that I keep in my mind when dealing in complex systems is that it's about improving the interactions between the parts of a complex system, rather than trying to change the structure of a complex system. And this is something that tends to get lost in widespread systems change. So often there is a desire to change structures rather than try and change the way those structures engage with each other and with the system overall. And that, I think, is a real important lesson that I've learned through my time of working in the NHS and beyond. And then finally, it is important to remember that actually looking after yourself and looking after the people that you work with is the most important part of managing in a complex system, because constant change is wearing, it is intellectually challenging and emotionally draining. And therefore paying significant attention to the needs of colleagues and individuals who are involved in that process is absolutely vital. Otherwise, people just withdraw from the process of change, and that then doesn't allow for a successful outcome to emerge through that process.
Now let's flip the conversation completely, because we've now talked about systems change, but we'd like to talk about the individual again, and in particular the patient, because one of the things you've spoken about is about the importance of GP education for patient outcomes.
Yeah, I think that there's been a long-standing discussion, and particularly if you read the literature around medical education, there is a significant focus on aspects of education such as recruitment, assessment, educational delivery, methods of teaching, methods of learning, And actually, there's very little written in the literature about to what purpose. So what is the point of the architecture, the infrastructure, and the theoretical pedagogy that exists within education, if not about improving patient outcomes? And so much of my work has been to try and demonstrate that actually clinical education, particularly delivered at the coalface of care, actually has impact on patient outcomes. And the reason for that is really, really important to me, because actually, when we produce the doctors of the future, or for that matter, the healthcare workforce of the future, actually in the process, we're also doing something else. We're actually changing the front end of healthcare. And we can now begin to see that actually when we have GPs who train, not only do they produce GPs for the future, but they're actually in real time also making a difference to patient outcomes, patient care as well. So education doesn't just have the function of creating the future workforce. It also has the function in the here and now of improving patient care. And that bit of the conversation, in my experience, tends to get missed. So universities and deaneries are very, 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 very focused, and rightly so, on the experience of the student or the experience of the junior doctor in helping them become the professional of the future. What we ought to remember is that just as important is the impact of that educational activity on patient care as well. And there are multiple reasons why that happens. But actually, at the heart of pretty much everything that I'm trying to achieve is the belief that by actually improving the experience of the workforce, we're also doing something else. We're changing the system in a way that improves the experience of the patient as well.
I guess that also fits in with your interest in peer-based education and development.
Yeah, so there is a lot to be said for learning from each other. Often some of the most important conversations don't take place between people in a hierarchy. They take place between people who are working or learning at the same level, and that is because I think that we bring a kind of similar context. Peers bring a similar context, but they also have differing experiences, and that sort of sweet zone between diversity of thought, but a commonality of understanding about the context of the individual, brings the opportunity to learn in a way that is different to perhaps learning that comes from being a part of a hierarchical relationship.
Well, within this context of education, tell me a little bit about your interest in relational ethics.
So, a few of us, a couple of years ago, a bit longer now, started to feel slightly uncomfortable that our clinical work, but also our educational work, seems to be seen through the lens of the 4 principles that have been taught since time immemorial within medical schools. And that perhaps they are not reflective anymore of the increasingly complex nature of the work that clinicians do. And is there a need to consider perhaps thinking differently about ethics in the context of clinical care, but also that actually one can take a snapshot in time and apply the 4 principles to that snapshot in time, say, for example, a consultation or an interaction between a doctor and a patient. But actually, in general practice in particular, but also in other avenues of life, relationships are longitudinal. They take place over time. They take place over space in different venues. And perhaps what's needed is is a more sophisticated understanding of the nature of the relationship and the impact that it has on ethical thinking. And so we spent a little bit of our time over the last few years thinking about autonomy in particular, patient autonomy, clinician autonomy, the nature of the relationship between the two, particularly in the context of an ongoing relationship between a doctor and a patient. So that's the nature of the work that we've been trying to undertake, an analysis that we've been trying to undertake. And underpinning it is also a belief that actually we all work in complex systems and we have complex lives. We have many, many influences that we bring when we come together, patients and doctors come together, and that those influences are not necessarily visible. And at the same time, how they then influence decision making, and in particular, the ability to make decisions for oneself, are quite important.
Within the context of the consultation, I see you bring a new dimension to the consultation, and forgive me if I pronounce the word incorrectly, but it's hermeneutic. What does that mean?
Hermeneutic. Yes, thank you. That's an interesting area that we're currently doing some exploration on. Actually, I'm not the lead for this. My colleague, Dr. Rupal Shah, is the individual who I think is driving this along with a couple of others. The belief I think we have is that helping patients make sense of what they're experiencing will have a much greater impact upon their ability to make wise decisions for themselves. And that one of the risks we see is that with an ever increasing pressure to measure, to calculate, to follow a guideline, what is happening is that time to help individuals, patients make sense of what they're going through is getting squeezed out. And because it's getting squeezed out, it means that patients are leaving our consulting rooms feeling frustrated, incomplete, and unhappy with their consultations. But the kind of sort of mushrooming of guidelines, of protocols, of a desire to template and to measure everything also means that the nature of the way we educate the future workforce is also changing, because we're having to teach people to kind of sort of get to grips with guidelines and apply them in clinical practice, or learn how to use computers to template data. And so we're being taken away, I think, from an important aspect of care, which is about helping patients make sense of what they're going through, because that requires quite sophisticated capabilities, reflective practice, advanced communication skills, and understanding about the ethics of medicine. And so that's why we introduced the idea that alongside all those other capabilities that a doctor requires, they also require an ability to help patients understand, make sense of what that individual is going through. And so that's part of the sort of journey of the writing that we're undertaking around sort of hermeneutics.
That leads us very nicely into my final question, which is about the paper you wrote in The Lancet, which is entitled Different Ways of Knowing.
Oh, yes, indeed. Yes, Domhnall, I think thank you for flagging that. That's an article that Rupal Shah and I wrote. And actually what we were doing was we were trying to recognize that there are many ways of knowing that extend beyond the measurable and the observable world. And over the last 30 years, healthcare has shifted its lens very much towards measuring and observing what goes on with the human state. But actually, there are other ways of knowing as well. There are sort of aesthetic, there are ethical ways of knowing that there are sort of bounded ways of knowing that exist that we continue to use in clinical practice. So for example, I heard someone the other day say to me, I actually hardly ever use guidelines in my clinical practice, because actually what I sense from my patients is something else that they need. And so that space to be creative with a patient and think differently about what my solutions look like requires clinicians to step above and beyond the guideline and seek information that is also biographical, not just biomedical. And for me, I think reinstating the value and importance of different ways of knowing beyond the biomedical is really important. I think we do also need to acknowledge that body of thinking actually originated in the 1950s and 1940s and 50s in the United States, and it originated from nursing. So we have a lot to learn, I think, from professions outside of medicine about the nature of knowledge, the nature of knowing, and the importance of it as well, in terms of how we then help people through their journeys in life.
Sanjiv, I love that idea of the biographical. And that really applies to you because you've really broken the mold of our conception of what the GP academic is. Sanjiv, thank you very much for that chat this morning. It's been fascinating chatting to you. Thank you very much indeed.
You're very welcome, Donald. Very welcome indeed.